Hello, everyone. My name is Adrienne Joseph. I am a medical student at the University of Texas Southwestern.
Hi, everyone. My name is Laila. I'm also a medical student at UT Southwestern.
We've been working with Dr. Chong through this past year on his lupus studies. And so today we'll be telling you a little bit about lupus of the skin. So these are Dr. Chong's conflicts of interest. And here's the outline for today's talk. So first we'll be talking about the different types of cutaneous lupus, erythematosus, or skin lupus. We'll also go over disease activity and disease damage, as well as treatments for cutaneous lupus. Then we'll go through some new drugs that are being developed for cutaneous lupus. And then we'll talk about some of the clinical trials that we have going on here at UT Southwestern. So cutaneous lupus, as you all may know, has a significant impact on patients' quality of life. There's the acute symptoms such as disease activity that includes itching and burning that can really have a great impact. There's also chronic signs of cutaneous lupus, which we call disease damage, that can have a significant impact on patients' quality of life. And these include pigmentary changes and scarring. There's also medication side effects that patients have to deal with. It can also affect social interactions as well. You know, patients may try to avoid social situations as a part of their skin disease. And then studies have also shown that cutaneous lupus can have a significant impact on patients developing depression and anxiety. So about 70% of patients with systemic lupus have skin and mucous membrane lesions. And there are three different types of cutaneous lupus, including acute cutaneous lupus, subacute cutaneous lupus, and chronic cutaneous lupus. And these designations are based primarily on the morphology of the skin lesions, as well as for how long the lesions last. So patients with acute cutaneous lupus usually have systemic lupus. This is acute cutaneous lupus is most associated with systemic lupus. It usually occurs after sun exposure. As you can see in this patient here, it's kind of like classic butterfly rash. It's associated with burning, swelling, and itching. And other than kind of having it on the face, it can also develop on the arms as well. And this rash usually lasts days to weeks. The next subtype of cutaneous lupus is subacute cutaneous lupus. And this type of cutaneous lupus typically affects the trunk and the upper extremities. It can come in kind of two different morphologies. There's this more ring-like or annular looking rash. And then there's another type of rash that can be seen with this subtype that looks kind of like psoriasis or psoriasiform. This also occurs in sun-exposed areas and can last for weeks to months. And it has actually also been related to some medications. So patients who develop this rash may want to, check with their doctor to see if it's any of their medications that they started that has resulted in this kind of rash. The next subtype that we'll talk about is chronic cutaneous lupus. And chronic cutaneous lupus has many different subtypes, with discoid lupus being the most common form. And then other subtypes that are included under chronic cutaneous lupus is lupus panniculitis and Tumid lupus. So first we'll talk about discoid lupus, and discoid lupus is commonly associated with scarring and pigmentation changes. It's actually the most common form of cutaneous lupus, and about 20% of patients with systemic lupus have discoid lupus. The next subtype of chronic cutaneous lupus is lupus panniculitis. And this is a form of skin lupus that actually involves the fat underneath the skin. So these lesions typically will start as these tender spots in the skin, and then they can go on to cause these indentations, which you can see demonstrated in this picture here. And these lesions typically occur on the face, upper arms, buttocks, thighs, and trunk. And then sometimes these lesions can actually develop some like calcium deposits in there, and that can be quite difficult to treat. And then the last form of chronic cutaneous lupus that we'll discuss is Tumid lupus. And this is, very photosensitive or sensitive to the sun. And these lesions are usually itchy or tender. You can see in the photo here that they're usually pretty red, pretty swollen. And these lesions actually respond really well to hydroxychloroquine, which is a medication that's commonly used for lupus. So as far as diagnosing skin lupus or cutaneous lupus, it's really based off of what we see in the clinic or your clinical examination that's performed by your physician. Skin biopsies can also really help, clinch the diagnosis of cutaneous lupus. And so basically the physician will take a little sample of your skin, send it off to the lab so that they can look under the microscope at the skin and see if there are changes that are consistent with cutaneous lupus. And there's actually no blood test that will make the diagnosis of cutaneous lupus. So it's all basically what your physician is seeing clinically on your skin and what the microscope is showing. So next, we'll talk about disease activity and treatments.
Awesome. So cutaneous lupus has an active phase followed by a damage phase. The active phase is characterized by redness, scaling, oral ulcers, and hair loss, as we'll talk about in the subsequent slides. And damage is characterized by different features such as scarring, discoloration, and atrophy. Most treatments for CLE, such as hydroxychloroquine, steroids, or mycophenolate, are aimed towards the active phase of CLE or skin lupus. So the signs of disease activity in cutaneous lupus. The first sign that we'll talk about is redness. So this is the most obvious sign that the disease is active, and probably there needs to be some adjustment to treatment regimens. Often in patients of color, redness can be a little bit hard to appreciate, but that's not the only sign of disease activity. Other signs of disease activity include scaling, as we can see here in the two pictures that are presented, and also oral ulcers or mucous membrane lesions. And lastly, new or worsening hair loss. If you're experiencing any of these signs of activity in skin lupus, it may be a sign that treatments need to be adjusted. Some of the treatments for disease activity in cutaneous lupus are what I'll talk about now. First, sun protection is extremely important in skin lupus to prevent worsening activity and damage. We recommend daily sunscreen with SPF 30 or higher, broad spectrum sunscreens, and that could be either physical or chemical depending on patient preference. We recommend 1 ounce of sunscreen to the entire body 15 to 30 minutes before going outside, using at least a quarter size amount on the face, and then reapplying every 2 hours. Other forms of sun protection include just avoiding being outside between 10 a.m. to 4 p.m., and also wearing sun protective clothing, such as wide brimmed hats, sun protective clothing with UV protection factor 15 or more, sunglasses, and long sleeves. Besides sun protections, there are, of course, drugs that are used to treat activity in cutaneous lupus. The commonly used medications for skin lupus have varying strengths and side effects. Here we have listed a bunch of medications in ascending order of strength. So kind of the least invasive medications that we provide include topical steroids and injected steroids. There's a treatment ladder that moves up from hydroxychloroquine to other medications such as azathioprine, mycophenolate, and methotrexate, and finally prednisone, which is an oral systemic steroid that is used when patients are flaring, but is generally not a great long-term medication because the stronger the medication, the more serious the side effects can be. Next, we'll talk a little bit about disease damage in skin lupus.
Yeah, so I'll be talking about the disease damage. So the first sign of damage is dyspigmentation. And so dyspigmentation can be broken down into hyperpigmentation and hypopigmentation. So hyperpigmentation is essentially just dark spots on the skin, and then hypopigmentation are lighter spots on the skin. Another sign of disease damage in cutaneous lupus is scarring, which is, just a mark that has been left on the skin that was previously affected by lupus. And scarring is frequently associated with dyspigmentation. Atrophy is also a sign of skin damage in cutaneous lupus. Atrophy is defined by thinning of the skin and underlying tissues that result in depressions in the skin. And then the last sign of disease damage in cutaneous lupus is scarring alopecia. And in scarring alopecia, the hair follicle is damaged, and that's what differentiates it from non-scarring alopecia. So since the hair follicle is damaged, the hair unfortunately will not regrow in that area. So now I'll talk about what treatments there are for disease damage in cutaneous lupus. But first, I would like to give a disclaimer that there are a few studies actually investigating the treatments for disease damage in cutaneous lupus. Therefore, none of these treatments are actually proven. And many of the treatments for disease damage are usually recommended for people who have had inactive disease for at least 1 year. So first, I'll just kind of reiterate the use of sunscreen. So sunscreen can actually prevent worsening of hyperpigmentation as a result of CLE lesions, and essentially it works by preventing worsening of the dark spots by the sun. It's a convenient and affordable way to kind of like prevent worsening of darkening in these areas. However, it's important to note that sunscreen will not actually lighten the dark spots. Makeup is also a really great option for hypopigmentation, hyperpigmentation, and scarring. It can really help reduce the appearance of these things. Patients can also get custom-made makeup to match their skin tone. And this is, a pretty good option to temporarily cover the dyspigmentation and scarring. Topical hydroquinone has also been used for hyperpigmentation. It's essentially a cream that reduces melanin production, which results in lightening of dark spots. It's pretty affordable, fairly convenient. For higher percentages, you do, however, need to see a physician in order to get a prescription. The cream can be irritating to the skin, and typically in CLE patients, there's not a dramatic improvement in the hyperpigmentation, but there will be some lightening of the lesions. This treatment option does take many months to see improvement. Fillers have also been used to improve the appearance of atrophy. So filler is essentially injected into the skin to improve atrophy. It's a quick, procedure if they can do it in the physician's office. However, it can be pretty expensive. It might require multiple treatment sessions. There is a risk of nodules forming under the skin from the filler, and there is a theoretical risk of reactivating CLE lesions as well. Lastly, wigs and extensions can be useful for camouflaging areas of hair loss. Wigs are pretty versatile. They come in a variety of styles and price ranges. However, again, it is only a temporary fix, and improper use or installation of wigs can cause hair breakage as well. So next we'll talk about new drugs for cutaneous lupus.
Yeah, so the first drug we'll talk about here is called lenalidomide. So lenalidomide may help patients with refractory cutaneous lupus, meaning skin lupus that is not being treated by you've gone through a lot of treatments and nothing really seems to be helping. It's related to another medication known as thalidomide, but it's a stronger medication. Doses range from 2.5 to 10 milligrams per day. And it's been used to treat hematologic malignancies such as multiple myeloma. Several small case series have shown that this has helped patients with skin lupus with refractory disease. However, there are multiple serious side effects associated with this medication, some of which are listed here on the slide, such as decreased blood counts, increased risk of clots, and birth defects. Unfortunately, the medicine is also pretty expensive. So here at UT Southwestern, while we have found this medication helpful for some patients, we really feel that this medication needs larger studies before we can wholeheartedly recommend this medication to be used. There are also several treatments in clinical trials for systemic lupus that may also be effective for cutaneous lupus, as a lot of these trials are beginning to include patients with severe skin disease as well. One of these promising medications is anifrolumab, which is an IV medication that targets a specific receptor called the interferon alpha receptor, and it has shown a lot of promise in lupus trials. So there was a recently published phase 3 clinical trial that showed that more anifrolumab treated patients with cutaneous lupus showed treatment response compared to placebo alone. Adverse effects were minor, and the medication was generally well tolerated, and the most common side effects included headache and infections such as upper respiratory infections and UTIs. And then lastly, antibody targeting plasmacytoid dendritic cells. This is another treatment that's under investigation in order to help patients with systemic lupus, and again, may show promise in patients with cutaneous lupus. So this is a monoclonal antibody that targets plasmacytoid dendritic cells. Currently, this is under phase 1 trial of 12 patients with SLE, which is systemic lupus, and active CLE, which is skin lupus. The medication was given IV, and 6 out of 8 patients in that study showed clinical response in the skin. Phase 2 trial, which has also been underway, shows improvement in skin disease activity. So these are just a couple of therapies that may kind of emerge moving forward in the next few years as new drugs for cutaneous lupus.
So next we'll be talking about some of the clinical trials that we have going on here at UT Southwestern. And here's just a list of some of the trials that we have going on. The first is the SMILE trial. We also have our CLE Observational Study, and then our UT Southwestern Cutaneous Lupus Registry. So the SMILE trial is really looking at a progression of cutaneous lupus to systemic lupus. About 15 to 20% of patients with cutaneous lupus will go on to progress to systemic lupus. And then patients with incomplete lupus, or patients who have, some symptoms of systemic lupus or some laboratory tests suggestive of systemic lupus, but don't necessarily meet all the criteria for systemic lupus, can also progress to meet that criteria. And about 20% of patients with incomplete lupus will go on to be diagnosed with systemic lupus. Patients who are first-degree relatives of those with lupus are also at risk of developing systemic lupus as well. So currently there's no treatment that exists for preventing lupus. Hydroxychloroquine is, as we said, kind of often used as the drug of choice for lupus. However, there's no real data that supports its use in preventing the development of lupus. And that's kind of what the SMILE trial focuses on. So basically with the SMILE trial, does is give patients who are at risk of developing systemic lupus hydroxychloroquine, and they give them 200 milligrams twice a day, or placebo, and then follow these patients over time to see if patients who are in the hydroxychloroquine group are less likely to develop systemic lupus than patients in the placebo group. And here are just kind of the criteria to be in the SMILE trial. Patients have to be 15 to 50 years old, have 1 to 2 lupus symptoms or laboratory tests suggestive of lupus, have a positive ANA or anti-nuclear antibody test, cannot have other autoimmune diseases, and cannot have been treated with hydroxychloroquine. The benefits of being in the study include that the medication is provided at no cost. With hydroxychloroquine, you have to get eye exams, and these are provided complimentary to those who are in the trial. And then patients will also be compensated for their time. So if you think you might qualify or know someone who might qualify and would be interested in enrolling in the SMILE trial, you can email smile@utsouthwestern.edu, or you can reach out to this phone number listed here. So next. Next, we'll talk about our CLE observational trial. So with the CLE observational trial, is basically just looking at, following patients over time, just to see how, medications work in some patients, and just seeing the natural course of lupus. So patients are seen at 2-month intervals, and at each visit, patients are given questionnaires. Dr. Chong will do a physical exam, and then photographs will be taken as well. In order to be enrolled in the CLE OBS trial, you have to be at least 18 years old, have a diagnosis of cutaneous lupus. And then the benefits of being a part of this study include having extra time with specialized researchers in lupus. You're not giving any experimental drugs. You're just going to there's kind of following you over time, and you'll also be compensated for your time as well.
So the UT Southwestern Cutaneous Lupus Registry, this was started in 2008 by Dr. Chong as a longitudinal observational study of patients with skin lupus. Our goal is to improve methods of diagnosis, prognosis, and treatment of patients with CLE, and to provide insight into disease pathogenesis. We primarily recruit patients from 2 hospitals, the UT Southwestern and Parkland Hospital. We collect clinical data and blood and skin specimens over multiple visits for each patient. At this point, we have enrolled more than 348 CLE patients from a variety of races and ethnicities. Some of examples of our research from our registry have included the following, which I'll talk a little bit about here. One of the things that we've been really interested in is looking at our skin lupus patients and identifying what characteristics put them at higher risk for developing systemic lupus. We have identified multiple risk factors, such as having generalized lesions present below the head and neck, aka generalized DLE, and nail changes, arthritis and arthralgias, worsening skin damage, and abnormal lab values, such as a positive ANA, all of which put patients at risk for getting systemic lupus if they have cutaneous lupus. We have also been able to track long-term how patients with CLE have done with our standard of care treatments. We have looked at 83 patients and found that most of them either had improved or stable disease activity trends.
We also found that those who were most likely to show improved disease activity included those with high initial baseline activity and damage scores of at least 10, minority race, and disease duration of less than 1 year. We also found that those who showed improved disease damage tend to have high initial Class C damage scores of at least 10. The CLE Quality of Life Questionnaire is a disease-specific quality of life questionnaire for CLE. So with the help of one of our colleagues at the University of Oklahoma, we designed a disease-specific patient-reported outcome measure for CLE called the CLE QOL. This was done to better assess how patients feel about their CLE and give patients a voice on how treatments were working. We designed this questionnaire based on input from focus group studies and has a variety of questions on the signs, symptoms, effect on daily and social activities, and appearance. We have validated this questionnaire and it will soon be used in clinical trials for CLE. The following here is our email and phone number for contact information if anyone is interested in has any questions or is interested in participating in any of the studies that we've talked about. Upcoming trials that's kind of in progress include a new phase 3 trial for lupus using an antibody against plasmacytoid dendritic cells, excuse me. I had discussed this a little bit before. And then also a phase 2 trial, again for lupus using efavaleukin alpha, which is an IL-2 fusion protein. We'd like to acknowledge the following people, including everyone in our Chong research group here at UT Southwestern, some of our colleagues also in the Department of Rheumatology at UT Southwestern, as well as some of our collaborators at Penn State Hershey Medical Center, the University of Oklahoma, and the University of Pennsylvania. We'd also like to acknowledge the U.S. Department of Health and Human Services and the NIH, as well as the Rheumatology Research Foundation for their support. And lastly, the Dermatology Foundation. Thank you all so much for listening to our talk, and please let us know if you have any questions. Thank you.